Welcome to Eye Contact, a video news programme on issues and controversies in ophthalmology, sponsored by Eurotimes. I'm Richard Packard. In spite of significant improvements over the years in visual outcomes following cataract surgery, there are still cases where postoperative ametropia occurs. Ophthalmic surgeons have a number of options available to deal with such cases. Today, we will be talking about solutions utilising laser refractive surgery with Dr Vikentia Katsanevaki, Head Refractive Department, Orasis Eye Centre, Athens, Greece. Welcome, Dr Katsanevaki. First of all, what percentage of cataract cases now require follow-up refractive surgery, and has the situation really changed and improved over time?
Hello, it's nice to be here and thank you for inviting me. Nowadays cataract surgery is not cataract anymore. It turned out to be refractive surgery. The age group of cataract patients goes lower and lower as nowadays the needs of a 60-year-old are not the same as it used to be a few years back. From this point of view, the patients are more demanding, and especially those who seek for premium IOLs. You can understand that the patient that would overpay a multifocal lens wouldn't be very happy if he doesn't get what he was promised before the surgery. It seems from the registry of Eric Waugh that the number of ametropias post-cataract surgery is not that low, and it turned out to be almost 45% of the registered patients implanted with either monofocal or multifocal lenses that had some portion of ametropia after the surgery. As you understand, this becomes an issue.
It's a very high proportion.
These are the published results from a multinational study engaging more than, I think, 17,000 eyes.
So, there are several options for treating pseudophakic refractive error. And when do you consider a laser approach, and who would you think are the best candidates for this?
Well, from my point of view, there is a dual answer here. First is whether the laser is available. Most of cataract surgeons have some access to a laser suite, and from this point of view, if laser is available in the most of the cases, if we exclude patients that have optical complaints because of multifocal lenses, which is a percentage, I don't think laser can help in that.
No, it's a different issue.
Exactly. Or patients implanted with toric lenses and have some residual postoperative astigmatism, which can be treated with simple rotation of the lens. I think that for all the rest, or at least in most of these cases, when laser can be done, I think it's a better option in terms of efficacy, predictability, and safety, of course, considering that laser is a procedure outside the eye, so it carries so less risk.
So, Vikentia, you've made the decision that you're going to use the laser. Which would be your preferred option, LASIK or PRK, and are there any special indications as to which one of those you would actually use?
More or less are the same as to my primary refractive cases. Lower corrections, you could consider to do PRK. Higher corrections, especially mixed astigmatism, hyperopic corrections perhaps, it would be nice to do PRK because they will regress. So more or less it's the same indications like the primary patients, along with the precautions you should take in terms of thickness, topography, stability, etc.
And when you say stability, how long would you normally wait after surgery before you would regard somebody as being stable?
Ideally, I wouldn't I would be reluctant to do it before the 3-month interval, as it seems that the cornea is still changing and probably the lens is being settled into the bag. But in any case, you need to have at least 2 consecutive topographies that show the same pattern, so you're sure that the cornea is quiet.
Okay, now you talked earlier on about, in the case of astigmatism, that a lot of the time if you put in a toric lens you might just have to rotate it a bit. There are going to be some patients where unexpectedly you may get more astigmatism after surgery than you reckon on. How would you generally deal with that? What choices do you have for dealing with astigmatism?
Like I said, if you had a preoperative astigmatism, I assume that the surgeon will choose to use a toric lens, and therefore a simple rotation could do the work. But in cases of surgically induced astigmatism, that happens to anyone, I must tell you, ideally I would like to do LASIK on these patients. I'm not very happy with PRK and astigmatism because in most of the cases they regress.
Mm-hmm. And what about incisional approaches? Do you use those at all?
From my point of view, the incisional approaches are not that, it's not a meticulous approach, to put it this way. They may work in very high corneal astigmatism just to reduce the amount of astigmatism and then do the fine-tuning with the laser if needed.
And if you had a femtosecond laser available to do the incisions, would you use that? Do you think it's worthwhile?
Of course I would, if I had one, of course.
Now, we know that there are lots of IOLs out there, particularly multifocal ones that are becoming available. Do you think that these lenses present special challenges in terms of getting the ideal post-operative result?
Well, if this is a challenge, you overcharge the patient promising the perfect optics and the perfect function. On the other hand, in a natural life, let's say in a virgin eye, a minor astigmatism could help. It increases the depth of focus, it may help you, being presbyopic like myself, could help you read. This is not the case with multifocal lenses. Multifocal lenses are not forgiving. And from that point of view, in such patients, probably are the single patients that you want to get them to zero.
Absolutely. Vikentia, thank you very much indeed for joining us, and for more information about what you've heard and this and other related topics, please visit us at Eurotimes.org. Thank you very much.
Thank you.